Welcome to the 2020 Watershed Congress. This is Friday, September 25th, day 5, the last day of our virtual Watershed Congress week. Thanks for joining us again today. The Watershed Congress is organized by the Delaware Riverkeeper Network in collaboration with many other organizations. My name is Cherry Town. I serve as Executive Director with the Delaware Riverkeeper Network. I'm your moderator for today's session, Sewage Treatment and COVID-19, How Wastewater Can Be a Tool in Determining the Magnitude and Extent of a Pandemic. We're pleased to present our speakers for the session. Matthew Meyer is the County Executive of Newcastle County, Delaware, which comprises nearly 2/3 of Delaware's population. Michael Harris is Manager of Newcastle County's Stormwater Environmental Programs Division. Now I'm going to turn it over to our presenters, and our first speaker today is County Executive Meyer.
Thank you so much, Cherie, and everyone who's joined us today. For coming to the Congress, and also for what you do every day to keep our watershed healthy and our communities healthy and sustainable for the long term. I really appreciate this opportunity, along with Mike Harris, to present to you what we've been trying to do with our sewage, with wastewater in the COVID-19 pandemic. Newcastle County has about 60% of the population of the state of Delaware. Among our responsibilities to the people of our county is running the largest sewer system in our state. Mike is an environmental engineer with the sewer system and has been heading our COVID-19 wastewater project. I like to say that wastewater systems are the greatest public health innovation of the past 500 years. Any of you who've spent time in a developing country in a place where they don't have good wastewater systems will certainly notice that health outcomes in many of those communities are significantly worse because of the absence of quality wastewater. And a lot of times that's how I think. A lot of times in my 4 years as county executive, that's how I've thought about wastewater. It's really public safety at some level and public health. In recent years, unbeknownst to me, I think Mike knew a bit about it. There have been technologies arising to use wastewater for public health, public safety in a preventative way, identifying what chemicals are being thrown down the drain, down the toilet, or shed through human stool down the toilet, to identify sort of what harm is out there, where it is, and enable people like me to develop quality, improved public policy to address those harms. That was sort of where we were, I think, in January, February, March this year when COVID-19 hit. I've really empowered everyone who heads our parks, our libraries, our police department, our paramedics, our 911 to look in innovative ways during COVID-19. I knew whatever we were going through in Delaware, it really started in mid-March, whatever we were going through, however we were going to get out of it, it was going to be through innovative ideas and the execution of smart, innovative ideas that stood the test of time. So I really encouraged those who work in the county, like Mike, to be innovative. Mike has an innovative strand to him naturally, I think. And so look around the country or around the world, see what cool stuff is out there that we could potentially put to use for us. We found, and I'll let Mike get into the details of how the program developed, what we've been doing the last 3-4 months, and what the future of the program is. From my perspective as a decision maker, someone who's making decisions each and every day on the public health of the community, on the safety of the community, on where to do COVID-19 testing, how much testing we need to do, and various measures we need to do to take the community, make the community safe during the pandemic. I really have seen the wastewater in the wastewater monitoring in 2 ways. One was to understand, get an early indicator of where we are on the curve, so to speak, to identify by taking COVID samples on a weekly basis from our primary wastewater treatment plant for the county. We were getting an indicator each week, or we're getting an indicator each week of where we are on the curve. Are the number of particles in our wastewater, COVID-19 particles, are they increasing or decreasing compared to last week, the week before that, the week before that? So that's one thing. It's just identifying where it's on the curve. Some people say, well, wait a second, you already have that through testing. We have, through our county government provided testing in Newcastle County alone, in the past 4 months, we've tested over 75,000 people. So it's quite a lot of people tested. The problem is it's kind of a lagging indicator. There's evidence that COVID-19 actually sheds through stool before it would even show up on one of our COVID-19 tests. And of course, there's a delay in getting tests returned. And also there's sort of disparate impact in terms of, there's a bias in terms of where our testing sites are. There are people who need tests or who have COVID who don't know they need to get tested. And a lot of those inconsistencies in human testing, you don't have them when you do wastewater testing. As someone on our staff likes to say, poop is the great equalizer. So one way it's helped is it's helped us to identify where we are on the curve. And another way it's really helped us is Mike developed a tremendous plan where initially we were just testing in one place in the county, but now we're testing, I believe, in 12, is it 12, Mike, different substations across the county. So we actually have a map where residents can go on to a map of the county and see how the prevalence of COVID in their neighborhood, in their region of the county, compares to other regions of the county based on the testing we did that week or the week before of their wastewater. So in those two ways, it's really helping us to develop policy. One policy that it's impacted, for example, is where we put our testing sites. We move our COVID-19 testing sites based on need. And when we see a spike of prevalence of the virus in our wastewater in certain areas, we add testing sites in those areas. So I just wanted to start by giving people sort of a high level view of how this is useful. It's something I've kept in mind throughout the process as we invest government resources, the people's resources in wastewater COVID-19 testing. And I'll leave it to Mike to get into more of the details of how we got here, the work we've done, and what we see going forward. Let me just add one thing that I think it's tremendously exciting, the future of this. One of my biggest stresses every day now, perhaps your stresses if you're a parent with school-age children, is how to get our kids and faculty and staff of our K-12 schools and our universities back into the buildings. One way that's showing that it may work is through regular ongoing testing of wastewater. You can imagine if a school takes a K-12 school, an elementary school, takes a daily test of wastewater, and we have a daily indication, we'll be able to have detection of spikes of the virus right away. In addition to when there's the next epidemic, when we hear that there's a dangerous virus or bacteria somewhere far, far away, we can start right away, activate our system and monitor our wastewater to detect those harmful virus and bacteria levels and take appropriate action. So without further ado, let me hand it off to Mike.
Thank you, Matt. That was a great introduction. Thank you. Thank you. So I'm going to start the presentation now. You know, Matt touched on this a lot, but we're the northernmost county of the 3 Delaware counties with, you know, 2/3 of the population. And our particular county government, we're responsible for police and paramedics, parks, libraries, buildings, stormwater management and operation of the sanitary sewer system. And in that regard, we have 3 wastewater treatment plants and about 1,600 miles of sanitary sewer that we operate. So getting into wastewater epidemiology, it's really an emerging field that looks for biomarkers or chemicals to assess the health of the population. It's can screen easily entire populations without worrying about, you know, HIPAA, privacy, getting people in to get tested, lack of testing supplies. There's really, you know, unlimited potential for this type of testing. In 2013, one of the big, you know, things that it did when it started off was it detected polio in Israel and really let them know that the virus was present there, and they, you know, were able to do a response based on this type of testing. the way the county got involved, we learned of a company called Biobot Analytics. There were a bunch of graduates from MIT that started this company, and they really got started testing for opioids in the sewer system to help that epidemic, that other epidemic that is being overshadowed right now by COVID-19, but still exists. And they got started, they did a study in Cary, North Carolina, where they went out to different sewer sheds in Cary and were able to determine which type of opioids were in different areas of the city. And they mapped that information with GIS, and they also mapped local pharmacies that were selling this, or that could be good ways to reach out to the public. And they increased public awareness in areas that they were able to really focus their public awareness efforts in areas that really needed it. And they've seen a 40% reduction in overdoses from these efforts. So you can imagine the vast potential here with wastewater epidemiology. So Biobot smartly pivoted during the COVID-19 epidemic and started testing wastewater for COVID-19 and started a pro bono study, a nationwide pro bono study. They allowed Newcastle County, we kind of came in late to the game. We learned about the study, tried to get in it. They squeezed us in because nobody else in Delaware was doing this, and they wanted to have representation in every state. So we got one sample, so we had to choose wisely, and we chose our Wilmington Wastewater Treatment Plant influent, which is our largest sewer shed. There's about 460,000 people, I believe, that contribute to that sewer shed. So we started getting one sample tested there every week. And then as we grew more comfortable, we learned the potential of this study. And as Biobot expanded and turned the pro bono study into a paid study, they allowed us to add some more sites. So we added 11 additional sites over time that could better determine the granularity, the extent, magnitude of things in our county. So here's a map, just giving you a basic idea. This is, I-95 runs basically through the middle of the upper part of the county, and then the C&D Canal is another divider of the county. So the majority of the sewered area is above the C&D Canal. That's the majority of the population is above the C&D Canal as well. Within the dashed line, that is the Wilmington Wastewater Treatment Plant collection area. So that's the first area we started in the beginning of our study. And then the different areas of the colored areas on the map are areas we added later on that make up the 12 sites we're doing now. You can see there's an area below the canal that is not shaded in, and that's because that area is either operated by the city of Middletown, Delaware, which is not part of the study. They opted not to be in it. Or that's area that is on septic and it's not measured. So the basics of the testing, this is how it works. The theory is, the known science is that infected people shed the COVID-19 virus through their feces. We're learning now that most of that shedding happens in the first few days of their infection, and that's kind of changed things, and we'll talk about that later in the presentation. But by testing wastewater that, where the feces have gone, you can determine the presence and amount of the virus present. And then if you know the flow, the concentration of the virus, and you know how much flow that represents, you can come up with the total mass loading of the virus. And then if there's theoretical numbers. I mean, the number that was out for a long time was an affected person shed 740 million particles of virus per day in their stool. So you can take that, you can divide the loading by the amount of stool, virus in the stool that people shed. You can come up with an estimate of how many infected people are in the sewer shed. And of course, if you know the population of the sewer shed, you can divide the estimated cases by the population of the sewer shed and come up with an incidence rate. So kind of, more of a graphical about how it works. This in the upper left-hand corner, this is an ISCO 24-hour composite wastewater sampler. What it does, it collects an aliquot, a sample from our sewer system once an hour for 24 hours, composites the sample together. We have these strategically located in areas that are major pumping stations, which collect wastewater from our catchments in the county. So we have defined areas that we're testing by through these wastewater samplers deployed. Our analysts take those back. They fill up containers, 3, I think 50 milliliter vials that Biobot provides. They fill in the chain of custody. We ship that to Biobot. We also provide Biobot with the flow data from the catchment area and the population, and a significant amount of money, because this stuff is not cheap now. When it went to pro bono to a paid study, it has significant cost. And what you get from that is what's now started out as a 2-page report, but now it's up to a 6-page report because the science keeps getting better. Here's an example of one of the more recent reports we got. And I'll kind of take us through some of the key information from the report. So the first thing you'll notice at the very top of the report, you can see that virus was detected, and you get a viral concentration, which is genome copies per liter of sewage. Remember, we're doing, if I didn't mention it before, Biobot does PCR analysis, polymerase chain reaction analysis, exactly the same analysis that is done on clinical samples for COVID. It's just being done on wastewater in this case. So it's the same machinery. You're concentrating the specific RNA particles from COVID-19, and you're counting them. So in this sample from the Wilmington Wastewater Treatment Plant, they counted 89,380 genomic copies of the virus per liter of sewage. And to the right of that, this is a relatively new thing. Not all sewage has the same amount of stool in it. Some wastewater sites have more infiltration and inflow from rainwater in it, or from groundwater, or some sites have more industrial flows. So Biobot started doing normalization of the virus by also measuring the PMMV virus, the pepper mild model virus, which is a common virus, unharmful, that's found in everybody's stool. So they're able to determine basically how much feces is in the sample, and they normalize and they adjust the amount, their calculations based on that. And then on the second page, this is the thing, the more catchy part of the analysis and the report. This is Biobot's estimate of how many new cases are in the county on that sampling day. And in this case, they estimated 33,600 new cases, which is 6.7% of our population that's going to the wastewater treatment plant. Now that case estimate has been refined recently, and I'll talk about that more later, but as you can see, that's a pretty shocking number. And then one of the more recent things that we're learning about this data, Biobot started plotting the normalized virus concentrations in the solid line versus the new cases in the county, the total new cases in the county. Now, this doesn't necessarily overlap exactly with our sewer area. This is including areas of Middletown and areas that are not sewer, but we're starting to see, scientists are starting to see that there's a correlation with the virus being detected in wastewater 5 to 7 days prior to actual clinical cases showing up. So that's interesting, and that should be interesting and useful information for public health officials. So our first observations when we got our first report back in April, there's COVID in our wastewater, and that was, I guess we shouldn't have been surprised, but we were initially surprised. On a day, I think our first sample was April 15th, there were 27 confirmed cases, new cases of COVID in Newcastle County by clinical testing, and Biobot estimated that there were 30,400 cases on that day. So that was a big shock to us. When we put that information out, the public and especially our wastewater employees were very, very concerned. But once they learned, I mean, these samples are collected prior to disinfection in the wastewater treatment plant. They're influent samples. So there's no evidence or nothing to believe, no reason to believe that the virus is not completely killed by disinfection before it goes out to the river. This analysis is measuring both live and dead virus particles of RNA. It can't discern whether the virus is alive or dead. There's evidence to suggest that the virus dies in wastewater. And our sewage system, because of disease, I mean, there's lots of disease in the sewer, is safely closed off from the public. So it's not something the public can stumble into or be concerned about or, be concerned with. And the actual number of populations affected is higher than human testing results reveal. But that should be, pretty self-evident because the results include asymptomatic people and other people not otherwise getting tested. So that's not a surprise. So what we've learned over time, what the data can provide, it can provide an estimate of the scope of the outbreak, independent from patient testing or hospital reporting, and includes data on asymptomatic individuals who aren't getting tested. It can provide decision support for health officials to determine the timing and severity of public health and make interventions and mitigate the overall spread of disease. And can also track the effectiveness of our interventions in the wind down period and serve, maybe more importantly, as a warning sign for the reemergence of the virus if it ever goes away completely and then comes back. So, if you're getting into this kind of work, it's important to know this isn't textbook science. It's not something that has been, vetted and gone through, multiple rounds of validation and everything. It's really cutting edge. In our particular case, we got in at the very beginning of it, and the methodology and reporting has changed several times throughout the study. And it's required us to retract stuff and explain things to the public. There's times where Biobot determined that a factor needed to be changed and the results were off by a factor of 1.5, and we had to put that out to the public and tell them that, hey, the results should be 150% more than they are right now. So you just have to know that going into it, that the science is getting better, but it is changing over time, and it will require you to adapt to those changes. We've seen from our time in the study some big improvements. The normalizing the data with that PMMV, the pepper mile model, virus marker has really helped to smooth the data out and make it take away the fluctuations and make it more reliable. And this recent methodology change in case estimates is something that just happened 2 weeks ago with Biobot. And the most recent thing they've learned is instead of the earlier predictions, as I mentioned, of how much virus people shed were based on people that already had the virus. I guess it was studies done in hospitals in Wuhan when this first happened, where they were actually measuring the virus in people's stool to see how prevalent it was there. And what has been learned now is that people shed more of the virus in the first few days before they even have any kind of respiratory symptoms or would know they were even infected. A lot of people complain about gastrointestinal issues at the very beginning before they get sick. And that's when apparently you shed most of the virus. So that number, that 740 million particles shed per day really is probably much higher if you look at people if you tested people early in the virus. And so now they're comparing clinical cases with their big database they have, the number of clinical cases versus the number of viral particles, and they've come up with a relationship there. So what they're providing us now is an estimate of clinical cases we're going to see in the next 5 to 7 days. So those numbers were way lower than they were before, but it could be providing much more useful data. So here's something from Biobot's website that specifically shows some Newcastle County data, and you can see a spike in R for the Wilmington wastewater plant. You can see on May 14th, there was a spike of viral copies in our wastewater. And then on May 21st, you can see the clinical cases kind of spiking up 7 days later. So that really is showing that this can be really something very important for predicting what's going to happen in the future. So what to do with all this data? Well, first we felt like it was very important to share this data in an understandable way with the public. So we started working with a firm called Compass Red, and they developed this nice interactive data dashboard for us. In the beginning days of sharing the data, we just had Excel spreadsheets, and people did not necessarily understand the data. So I encourage you to go on the site if you're interested. If you Google Newcastle NCCDE Biobot, this dashboard will come up, and it shows the weekly, testing prevalence by sampling site. You can click on each one of the sites. It'll show you the data over time, and it's very handy. The public can understand it, and people are looking at it, and we believe our public health officials are looking at it too. We are going to need to make some changes to it because the way that Biobot is changing their case estimates, all the data is going to drop dramatically because of the new format. So we're going to need to, we've started conversations on how to make this better, to show historic versus the new data. And then, as the county executive mentioned, we're using the data to focus on where to put the county testing locations, which are amazing. I mean, you can basically go almost at least three or four times a week and get tested and get results back within less than 2 days, which is amazing because I know people that live outside of Delaware are not having that same experience. To where to send PPE and to make guidance decisions about how to open and operate our facilities and the services we provide the county, the residents of our county right now. So going forward, we've entered discussions with the University of Delaware, who's very interested in helping with this work. We recently purchased them a new digital PCR unit and auto samplers and all kinds of equipment, which is going to allow them. We're currently doing 12 samples a week, and UD can do 60 samples a week with this new equipment that we purchased. And more importantly, they can provide, because we're not shipping samples out and that kind of stuff to a private lab in Massachusetts, they can provide almost same-day turnaround time, which when it comes to COVID-19, the faster the turnaround time, the better. So the plan, what to do with those that extra capacity is getting into sampling dorms and individual school buildings to really look for the virus, to look more, for presence or absence of the virus. So there's a plan. We're going to be doing some of the University of Delaware dorms in the upcoming weeks, where most kids are going virtually, but there are some students that did decide to come back to campus. So the thought is, and we're not sure exactly how this is going to work, but if you get a detection in the wastewater from the lateral leaving the building, then you would go to clinical testing and really focus your clinical testing and try and find out, what's going on in the dorm. Almost like pool testing, that people have talked about clinically, to get more people tested by, mixing multiple people's samples together to test. So that's upcoming on our radar, and that's exciting stuff can't wait to work on. So as we've been going through this whole thing, there's been a lot of media involved. And one of my favorite quotes from the county executive is, if Biobot services help Newcastle County reopen even a half day earlier, it's the best investment I've ever made. All this work, you can imagine, it's been a big investment in resources and in financially as well. So, But if we can get our economy open, if we can get people safely, kids back to school, I mean, what's the value in that? It's worth it. So I will stop my sharing now, and that's my presentation. I guess if anybody has any questions, I'd be happy to take this.
So we can, we'll wait a little bit here and see if any questions come into the Q&A feature. But I was going to ask Mike if you could just go back and talk a little bit more about the concept of pool testing, maybe clarify that for anyone who's not familiar with that terminology.
So pool testing is, I guess, when clinical PCR, you know, the kind of testing you would get done in the pharmacy or one of these test sites. Because supplies were short, people talked about, you know, combining people's saliva samples or their swab samples, and putting them in groups of, I don't know, 10 people or something, and just testing that one sample. And then if everything's negative, then everybody's negative. But if something comes up positive, then you will retest the people that were in that particular group. I think that's how it works for my knowledge.
So I have some other questions coming in here. Is there any CDC involvement with your studies?
Not particularly with our study. We've been kind of ahead of the curve, I believe, on this testing. We've shared our data with our local public health officials, with the Department of Public Health. Haven't really heard too much from them. We do know now CDC has recommended, there's some guidance on their website now about doing this and encouraging other municipalities to do this. And same with EPA. So EPA and CDC are now putting this out there and encouraging municipalities to consider this type of analysis.
You mentioned when it was starting out as a pilot, Biobot was looking for representation. Was Biobot connecting the different facilities where this kind of testing was being done? Is there networking and sharing of information, sharing of resources or ideas among the different facilities that were in the pilot or are now in the paid version doing this and sort of sharing ideas about how they're thinking creatively about how to use this information?
Yeah, they've done a pretty good job with that. They have a weekly, for all their clients, they have a weekly webinar that we all jump on and talk about our data and ask common questions we all may have. Going back to the reports, they share in general other people's information, but they still maintain privacy. They don't tell you per se what's happening in Camden, the Camden Sewer Authority, but they give you like kind of an order of magnitude of what they're experiencing in bigger geographical areas. So, yeah.
So I have a couple more questions here I want to get to. You mentioned live and non-active RNA is detectable in the samples. Does this mean holding times and refrigeration is less critical, not as sensitive as bacterial indicator testing?
I'm not an expert on this clinical testing. I can tell you one thing. UD is kind of going through this, and they're testing different hold times and different things. The first thing that all these labs do as soon as they get the sample is they autoclave it, or not autoclave it, but they pasteurize the sample to kill the virus, when it comes in. Our samples, we collect on ice in a refrigerated sampler or on an ice sampler. We keep them at 4 degrees Celsius. Ship them with ice packs, and they're autoclaved as soon as they get to the facility. UD did some experimentation, and they tried different hold times, and they tried pasteurizing. As soon as they received the sample, they let it, sit for a few days, and they pasteurized it, and they didn't see anything really of significance that shows that. So I don't know how important icing and pasteurization is in the process, but I think we're still learning as we go.
All right, I'm going to read another question here for you. This is an important new technology for tracking disease, and your town is commended. Literature suggests that only some individuals COVID-19 have gastrointestinal manifestation of the disease that precede the respiratory symptoms. Without knowing the percentage of these infected who have GI symptoms, can the increase in wastewater prior to the peak in tested diagnoses be a real predictor of the change in disease proliferation as measured by testing?
Yeah, these are all like really good questions. I think you're right. Like every person's not going to shed some people, shed their super spreaders. They shed at different rates. I think looking, these national studies have looked at the average person, the average response in the population. So I think the larger the population, probably the less variable that's going to be. But yeah, when we get down to like testing buildings, and there could, somebody that doesn't shed the virus or doesn't get those that GI response may kind of screw that kind of testing up and make it not as reliable. But I think when you get into larger populations, that becomes less of a problem.
You mentioned that evidence suggests that the virus dies in wastewater. Can you elaborate on that at all?
I just looked on it. I've been following, I believe I got information from the CDC about that, where at the time I did the research, there's been no evidence anybody got COVID from working with wastewater. And there was the studies I've seen, people have just said it doesn't make it in wastewater. It doesn't proliferate or become viable when it's in wastewater.
Waiting for, I guess we have another question down here. Speculate on CSO exposure.
On CSO exposure?
Mm-hmm.
I guess it goes back to your last question. I mean, if it's not, the virus is probably there, but the research I saw earlier on when I was studying this showed that the longer the stuff sits in wastewater, because I should make that point to the last thing you're talking about. Probably if you're in a rest area bathroom, when they don't have toilet lids and stuff like that, you're more likely to get an exposure there to a live virus than you are in something that's been in our sewer system for several hours. So I don't think CSOs, it's 100% that there's not live virus there, but the water, the virus has been in wastewater for some time. And I think the longer it sits in wastewater, the less viable it becomes and more likely it's dead than alive. I would say. I'm not 100% certain on that, but that's my speculation.
So as a former wastewater treatment plant operator, your work on this is really interesting and amazing to me, writes one of our audience. Keep up this important, great work. We have another question. Can Biobot be used to test for other applications like testing municipal water after filtration for traces of industrial waste chemicals that can also harm healthy residents? If chemicals from industry are isolated to what businesses create those chemicals, you could subject those businesses, holding them accountable to the cost of additional filtration. Do you have any thoughts on that?
I'm sure Biobot could do that, but there are other labs that can do that. I mean, we do that, the county runs a pre-treatment program, and we specifically test our influent and effluent, and we test, the 40 or so industries in the county that contribute to our sewer system using conventional labs. And, any chemical that would pass through a wastewater treatment plant that's a priority pollutant or an EPA regulated pollutant would not be allowed. So we put limits in place, we put permits in place on these industries to make sure they're not putting out anything that would pass through the treatment plant and cause harm. Now there are what they call emerging compounds that, like for example, certain hormones and like fire retardants, and PFAS is a big thing now, and things like that are not, there's no regulatory limit right now for wastewater treatment plants. There's probably going to be very soon, and then we'll have to come up and include those in permits and make sure that there's treatment at the pre-treatment at the facility before they discharge to the sewer, to make sure what's put in the sewer is effectively treated and doesn't pass through into the environment.
Another question here. Do the local school districts plan on using this technology to monitor students so that schools can open? You mentioned UD, but this seems to be talking more specifically about the school districts.
Yeah, I think that's our vision. The county executive's vision is to be able to go out to that level. We just ordered the new equipment for UD. I think it's actually part of it has arrived. So, you know, we're gearing up to be able to do 60 samples a week. I know our colleagues in Sussex County have recently started testing a school in that county. But I think that's the goal. Have had interest from schools about doing that type of testing. And I know like a lot of colleges are doing this testing specifically to, you know, get a handle on this and be able to do clinical testing and isolate kids and quarantine kids if necessary. So I think that's our goal, yes, but we're not there yet.
You mentioned that Middletown was not part of the study, but I think you just said part of Sussex County is. Do you have a sense of how much of the Seward part of Delaware is involved in doing this sort of testing in any way?
Newcastle County is really the only sewer system that is involved, with an exception. Sussex County, down by the beach, you know, the beach area of Delaware, they've done 2 small test areas. So I would say the vast majority of Kent County and Sussex County, none of Kent County is being tested right now, and the vast majority of Sussex County is not being tested.
You mentioned the portions of Sussex County, the beach area, was that something that they began over the summer, or is that when did they get involved in the study? When did their interest precipitate?
Just a few weeks ago, they've, you know, been aware of what the Newcastle County is doing, and you know, they've been encouraged by what we're doing, and they're kind of just dipping their toes in, so to speak, and seeing how it goes. But I think Sussex may, you know, expand to a higher level than they're doing right now, and perhaps Kent will join in at some point, but they're not there yet.
Is there what would you, if another sewage treatment system were to come to you and ask about this, about the possibility of implementing this for their system, what would your words of wisdom or guidance be?
I think it's a great idea. I would probably start, if you're starting out from scratch, I would probably look to Biobot, because Biobot is there's other people that do this analysis, but they don't provide they'll give you a number. They'll give you a number, a PCR viral titer number. And if you have the expertise to do that, to understand that number and to understand what it means for your population, you can probably, you know, go to another one of those labs. But if you want guidance through the whole process, if you want somebody to put the numbers in perspective for you, there could be other people, but our experience has been very positive with Biobot, kind of guiding us through the process. And we, of course, Newcastle County, if somebody would like to talk to me, I'd be happy to talk to anybody and help them through if they you know.
And County Executive Meyer had posted that link to the dashboard, and we are going to give us a little bit of time. We are going to try to get some of the resources that have been shared in chat, get them on the Watershed Congress webpage associated with the different presentations, but give us a little bit of time to do that. We can move some of that stuff over. I do want to wait just a little bit longer. Oh yeah, we do have another question here. You mentioned that this has lessened overdoses and that is commendable. Are there any laws that prevent this information from being used to arrest people, or is the goal to use this information for law enforcement? And do you have any concerns for any possible misuse of this technology?
As for the opioid thing, the opioid study, I mean, what we're doing and what they did in Cary, North Carolina, you're measuring it at points where there's complete privacy, anonymity. You cannot, it's not possible to know like where these samples and where this stuff is originating from. I mean, I suppose you could, you know, sample somebody's individual sewer lateral at their house, but I think there's other ways that would be, and I don't know about the privacy issues about that. Nobody in Newcastle County has any interest in doing that at all. No, I don't think anybody in Cary, North Carolina had any interest in that, but in general, I think I wouldn't be concerned about privacy and about police using this information. You talk about, you mentioned using this information for evil or for bad. I guess, potentially, advertisers could figure out who drinks caffeine, and people could see where people smoke by measuring nicotine. But that's, then again, the county would have to let people, in on that information, that we have no interest in doing that either. So,
what has the public response been to the information that you've been sharing on the dashboard?
At first, to the dashboard itself, people, of course, were concerned at first, like I mentioned, about wastewater being a vector for catching the virus. But after that kind of scare went out, the information, people have just have had the same kind of questions like we're getting today, and the response has been positive, and we've had interest in, like I said, from schools and other people that want to be included. So.
Well, we're, like I said, I am waiting to see if there are any additional questions here, but it does seem to sort of be slowing down on that front. And I do want to give Mike, you or County Executive Meyer, maybe any time here to maybe any sort of summary or additional last words you'd like to share before we wrap up.
Matt, do you have anything? Well, if not, I'd just like to say, we're very appreciative to put this information out. These are unprecedented times, and the county executives has really empowered all of us in the government to try and come up with innovative ways to help get us out of this. And we're all in this together, and we'd love to help anybody on here share additional information to help. So we're not holding this information. We'd like to share it as much as possible. So thank you for listening, and hopefully you have my contact information. I'd be happy to answer anything offline.
We certainly will share that information with our attendees. And with that, I think we're going to go ahead and wrap up this session, but I want to thank our speakers once again for taking the time to share their research with us during this week of Watershed Congress presentations. We do hope to see you in Pottstown in 2021 for next year's Watershed Congress. And with that, be safe, everyone.